Welcome back to the Waco Family Medicine Point of Care Ultrasound curriculum. This module will focus on using point of care ultrasound to evaluate the heart. Now, as you know, our residents practice in a variety of settings ranging from outpatient focused practices to full-time hospitalists and sometimes even critical access ERs or ICUs across the country. So my goal is to focus on a variety of both inpatient and outpatient applications of POCUS for cardiac complaints and clinical questions. Our first lesson will focus on the basic techniques and standard imaging windows used to evaluate the heart using bedside ultrasound. Have you memorized this slide yet? Remember, POCUS is a tool to answer a focused clinical question, not a full imaging study. This is particularly applicable when considering which patients are appropriate to examine using bedside echoes and being able to understand the limitations that these studies have when compared to comprehensive full echocardiograms. To further highlight this difference, let's compare and contrast a complete or formal echo with a limited cardiac POCUS exam. A complete echo is comprised of over 60 different views of the heart using a variety of tools to assess the anatomy, the valvular competencies, the flow volume, the velocities that's measured inside the heart, and there's a whole bunch of complex calculations used to assess cardiac function. It usually takes up to an hour to perform this exam and requires dedicated training to be able to get the correct windows and take the direct measurements that we need to give precise information. Meanwhile, a typical 4-window cardiac POCUS exam focuses on just a few high-yield windows that can be quickly assessed and give helpful, although incomplete, information. It helps us answer specific questions like, is there a normal ejection fraction? Or is there a pericardial effusion? Additionally, these determinations are made using inferential or qualitative assessments, meaning that we won't use a bedside echo to determine an exact EF, but rather to classify the ejection fraction as either normal or abnormal. Understanding the differences between formal and point-of-care studies helped me learn how to advocate when to perform an exam, but also know my limitations. It's an essential skill to learn. That being said, there's a good amount of high-quality evidence that supports non-cardiologist providers' use of POCUS. This helps them answer clinical questions, and a few of those articles are seen right here. Let's take a few minutes to go over the basics of a cardiac exam using point-of-care ultrasound. Whenever possible, remember that the convention in ultrasound is to have the machine and its operator positioned on the right side of the patient. The patient should be in the supine or semi-recumbent position with their precordium exposed and appropriately draped for privacy. Before placing the ultrasound probe on the patient, examine the patient using standard exam techniques, including auscultation and palpation of the precordium for the point of maximal impulse, thrills, and heaves. Also, take note of the patient's neck vessels and assess their JVD. To start the exam, the probe should be placed adjacent to the patient's sternum, with the footprint of the probe sitting over an intercostal space and the probe indicator oriented towards the patient's right shoulder. The probe of choice for these exams, when available, is the phased array probe, which is also sometimes called a sector probe or just a cardiac probe. This transducer is recommended for a few reasons. It has a smaller footprint than a curvilinear probe, which helps to image between the bony obstacles of the thoracic cage. It also provides a good compromise of temporal resolution, which is important in an organ like the heart that's constantly moving, while also providing enough depth penetration to image the cardiac base, which sometimes can lie deep in the chest. Our first roadblock and potential pitfall when performing cardiac ultrasound is that there's a large deviation from convention here that applies uniquely to cardiac exams. Typically, you may remember that the probe orientation marker on the screen typically lies on the left side of the screen, which intuitively matches the orientation held by the probe being oriented towards the patient's right side. In other words, the way that you're looking at your probe and the way that you see your screen don't seem to be flipped or backwards. However, in cardiac ultrasound, this convention's flipped, so it does seem backwards. Cardiac exams place the probe indicator on the right side of the screen, while continuing to orient the transducer towards the patient's right encephalate. While this does align with the anatomy of the heart, It can be disorienting, especially for people that are new to learning cardiac ultrasound. For those of us that are more visual learners, here's an example of a typical movement of the probe and the way this relates to the images generated on the screen. You can see that as we slid the probe to the left, which would be equivalent to moving the transducer towards the patient's right side, the image also appears to move in the same direction. If we, however, apply the conventions used in cardiac ultrasound, this movement reverses. So, for example, as we translated our probe in one direction, the area of the screen that's revealed appears on the opposite side of the direction of movement. All this to say, it takes some practice to understand how to navigate, orient yourself, and troubleshoot cardiac POCUS exams. Give yourself some grace if you get frustrated or disoriented the first few times that you practice. The remainder of this lesson is going to focus on the key images I want you all to recognize as optimal views of the heart that you should aim for when achieving a bedside echo. These 4 windows give us a great estimation of cardiac function and answer most of the clinical questions that commonly arise when caring for patients with suspected cardiac pathology. There are 4 standard windows of the heart with which I'd like you to be familiar at the conclusion of this module. The first 2 views are our parasternal views, meaning that they are images taken by imaging the heart in the small window found between the ribs next to the sternum, which overlies and protects the heart and other thoracic organs. There are long and short axis views in the parasternal area that each contribute helpful information to a cardiac assessment. Next, the apical 4-chamber view provides us with a side-by-side view of the left and right heart, and it's super helpful for comparing one side to the other and looking at the synchronicity of the heart, making sure that it's beating on both sides in the same time. Lastly, the Subxiphoid window provides a window through the heart that is more accessible underneath the rib cage. It can be helpful when we need to evaluate a heart during active CPR or when the views are otherwise difficult to obtain from the chest wall. If you've ever seen the cinematic masterpiece known as Mean Girls, you probably recognize these 4 icons. While each of these characters has their own strengths and own challenges, their own contribution to the "on Wednesdays we wear pink" dynamic, the movie wouldn't be the same without any one of them. Similarly, the views I'm going to introduce to you here have differing clinical utility. And while I won't dwell here on this poor analogy, feel free to come back to this slide after you've learned more and drop a comment if you agree or disagree with my assignments, or see if you can figure out which one applies to which. Let's start a review of the standard windows by looking at the parasternal long axis view. For this window, the heart is going to be examined in the long axis, meaning that the probe will be placed on the chest wall parallel to the lie of the heart in the chest, with the footprint centered just to the side of the sternum and with the indicator pointed towards the patient's right shoulder. If we think about our normal heart anatomy, we'd expect the atria to be located closer to the probe indicator, which means that they would be located on the right side of the screen. We'd also expect that the most anterior chamber of the heart, the right ventricle, should be closest to the transducer in the near field, occupying the top portion of our screen. And using our orientation as a guide, let's take a look at the real image now in the PLAX view. Great, so this is the key image I want you to have in your head when you think about a parasternal long axis view of the heart. Here, we see a phased array footprint with the probe indicator on the right side of the screen, consistent with the cardiac imaging mode. We see the right ventricle in the near field, close to the top of the screen, with the atria and the aortic outflow tract on the right side of the screen, and the left ventricle extends towards the left screen margin. Our quality checklist for this view consists of a longitudinal view of the left ventricle, making sure that we're not cutting it off at an oblique angle and underestimating the volume. The mitral and aortic valves should both be visualized in the same plane, and the depth should be set deep enough to see the descending thoracic aorta at the bottom of the screen, which I would argue isn't 100% clear in this clip. This window is particularly useful for the evaluation of left ventricular function. It's also helpful to estimate the systolic ejection fraction, and we can also make some inferences about large pericardial effusions, hypertrophic cardiomyopathy, and valvular disease, but these are more complex tasks. Just like the parasternal long axis view, the parasternal short axis view utilizes the window next to the sternum, but between the ribs to look at the heart. This time, we're examining it in a cross-section, or a transverse orientation. From the parasternal long axis view, the parasternal short view is obtained by simply rotating the probe 90 degrees, so that the probe indicator is now facing the patient's left shoulder. Thinking again about our expected anatomy, we would anticipate that the right ventricle, as the most anterior chamber, should again occupy the top of our screen in the near field. However, depending on the level of our transducer and the lay of the heart in the thoracic cavity, we expect to see a cross-section of the heart below this. And while I've labeled this image as left ventricle, since this is the largest structure we'll see, we can also see valves and other structures which I'll show you in just a minute. Here is our key image of the parasternal short axis view that I want you to be keeping in your mind as you try to obtain this view. Here we can see the right ventricle, which looks like a little crescent roll, sitting on top of the more circular left ventricle, which we're cutting in cross-section. We can see the mitral valve opening and closing with the cardiac cycle. It looks like a little fish mouth. And that brings me to a caution sign here, because the parasternal short axis view can and should change significantly based on where you catch the heart in cross-section. So let me explain this for a minute. So if we imagine that this is the heart sitting in the thorax, we could put our transducer at a variety of different places. For example, we could have it kind of cutting across right here, or we could have it a little bit higher, cutting across up here, or even all the way up here at the base. And accordingly, the cross-section view that we'd be getting is going to change depending on where our transducer is. Here, I'm going to place a blue line down here, and then a couple more. We could imagine that as we translate our probe, we could catch the heart at each of those different angles. And in fact, that's what we should be doing in a short axis view. Let me show you what that looks like. Down low, we might see a relatively small left ventricle with papillary muscles and little nubbins of the chordae tendineae attached to the wall and attaching to the mitral valve. So it might look like that. If we move up a little bit higher, we might actually see the mitral valve opening and closing sort of like a fish mouth. And then if we go up even higher, we might see actually the aortic outflow tract with the aortic valve and its Mercedes-Benz logo sign. So all of these different views are important to get because it helps you understand the full function of the left ventricle. So if you look at the bottom and the middle and the top of it, and you see it's all contracting concentrically during the cardiac cycle, then you know that there's probably no wall motion abnormalities. It's probably a pretty synced, good electric circuit within the heart, providing the signals that the heart needs to be able to contract well. Looking at all of these levels gives us the best understanding of how the heart's contracting. And it helps us best evaluate the anatomy of the left heart valves as well, which can be implicated in a variety of cardiac conditions. So once again, just to review, the complete parasternal short axis view, when indicated, should be conducted in multiple slices or planes. So this would include the Mercedes-Benz sign of the aortic valve, the fish mouth of the mitral valve, and the little nubbins of the papillary muscles at the cardiac apex. The parasternal short axis view gives us the best view of valvular anatomy and can help determine if the myocardium is contracting concentrically and uniformly. It also gives us some clues about the health of the right heart, but we'll have to have a whole lesson devoted to those findings. The apical four-chamber view is probably the most challenging of the four views to obtain, but it also gives us the most helpful information, in my opinion, to evaluate the heart as a whole organ. I mentioned that the apical four-chamber view is a more challenging view to obtain, but I hope I can try to demystify it a bit for you. For orientation, you should know that this view is optimally obtained by positioning the transducer footprint directly over the cardiac apex, with the probe indicator towards the patient's left side or shoulder, and the probe should be rotated to catch the heart in its long axis through all 4 chambers, just like the name would imply. I like to think of this as if you're using a flashlight to illuminate the whole heart like a jack-o'-lantern. If you just need to put the probe on the apex and shine the ultrasound beams through the heart, why is it so challenging to obtain? Well, for starters, unlike the parasternal views, which are more or less seen in the same place on all patients, the location of the cardiac apex can vary significantly from patient to patient. It's also more affected by positioning than other views. For some patients, their heart lies more or less vertically behind the sternum, and the apex lies close to the xiphoid process. But for others, their heart lies almost horizontally in the chest, and the apex might be displaced on the lateral side of the chest wall in the anterior or even the mid-axillary line. For this reason, I can't stress enough how important it is to examine your patient using your stethoscope and your hands before you rely on the ultrasound. If you know where the apex is, based on palpation of the point of maximal impulse or by auscultation, it takes a lot of the guesswork out of finding the apex on your ultrasound exam. And then you can focus on just optimizing the image by rotating and fanning and rocking your probe to get the right angles. Another tip to help explain how to get this view is by starting off with a parasternal view and then translating your probe in the axis of the heart down to the apex and then flattening out the probe angle and rotating to get the view. This is hard to explain verbally, so make sure that when you're rotating with me in POCUS clinic or when you get a chance to scan with me sometime, I can show you what I mean when I say that. Here's our anatomy schematic again, and as we would expect, if our footprint is placed over the apex of the heart, we should expect to see the ventricles, especially the left ventricle, occupying the near field of the screen in patients that have a normal cardiac anatomy. Similarly, if our probe indicator is oriented towards the patient's left side or left shoulder, we'd expect the left heart to occupy the right side of the screen closest to the probe marker. Parallel to the left ventricle and smaller is the right ventricle, and then their corresponding atria lie in the far field. The tricuspid and the mitral valves separate their respective chambers from each other. Let's go ahead and take a look at this on a real image clip. Here is a great apical 4-chamber view for us to review. At the top of the screen in the near field, we have the left ventricle predominating and extending to the right side of the screen. The right ventricle takes up most of the space on the left side of the screen, and it's approximately 1/3 to 1/2 the size of the left ventricle in a normal patient. The atria lie in the far field, and we can see the mitral valve and the tricuspid valves opening in unison during diastole and closing during systole. A couple other unique anatomical findings present in this view include an echogenic band, which I'll kind of circle here, that's present only in the right ventricle, in the apical end, which represents something called the moderator band. This can help differentiate right versus left if you ever get turned around or if you're ever doing a fetal echo for some reason. We can also see the trifold appearance of the aortic valve popping in and out of view right down here. When the aortic valve or aortic outflow tract is present, we sometimes call this view the apical 5-chamber view, with the aortic outflow tract representing this 5th chamber. The benefits of this view are that it highlights the comparison of the right and left heart, and it highlights the changes that occur in the anatomy of the heart during the cardiac cycle. And in fact, this is the predominant view to evaluate for right heart strain and cardiac tamponade. The challenge, like I mentioned, is that it can be a challenging view to obtain. Finally, our last standard view is the subxiphoid or the subcostal view. The subxiphoid view, as you might expect by its name, is obtained from below the xiphoid process and costal margin. With the probe indicator towards the patient's left side or towards the apex of their heart, the transducer often has to be pressed nearly flat against the patient's abdomen, as if you were trying to shine a flashlight up and under their rib cage to illuminate the heart. This view can be particularly uncomfortable for patients, so its utility is often limited to specific clinical scenarios. Our anatomic diagram here is a bit different than other views because rather than imaging into the thorax directly, this view is obtained by placing the probe over the anatomic abdomen. One benefit is that in some patients, the tip of their liver will abut the diaphragm and serve as an acoustic window through which the imaging of the heart can be accomplished. When this is the case, as you might expect, the liver lies in the near field of the top of the screen, with the highly echogenic diaphragm and pericardium lying in the midfield, and then the right ventricle deep to them, sliding over the pericardium in the mid or far field. Here is a still image of the subxiphoid view that was obtained in an emergency room evaluation. About half the time that you see a subxiphoid view, you'll see this view with the probe indicator marker on the left side of the screen. This can be due to the machine presets, but also it's because it's a standard view of the FAST exam, which typically starts out using an abdominal preset on the machine and often doesn't change to use a different mode or to use a different probe in order to quickly evaluate a patient without having to fiddle with the settings on a machine. Our imaging checklist, regardless of which side the probe indicator is on, includes the relatively homogeneous gray, starry sky looking liver in the near field, with a hyperechoic or bright diaphragm and pericardium, which are usually indistinguishable from each other, separating the right ventricle from the abdomen. I mentioned that this is a view that we often obtain during the FAST exam, so you might be able to surmise that this view is useful for evaluating a large pericardial effusion, which might be the case in a traumatic hemopericardium. Additionally, this view avoids valuable real estate on the precordium, so it can be useful for evaluating cardiac activity during CPR when leads or hands or instruments may need to otherwise be placed on the chest to help resuscitate a patient. However, the limited views and the oblique angles of this window limit its utility for other clinical scenarios. So that is a brief introduction, and I know is a lot of material to cover for the typical cardiac windows and standard conventions of a cardiac exam. As a recap, we talked about preparing for cardiac POCUS, including how we position our patients and how we need to think about doing a limited exam or when it might be more appropriate to order a formal echo. We talked about the basic scanning conventions, including the unique finding that we often flip our screen and have to flip our orientation in our 3D minds to be able to understand the anatomy that we're finding on these exams. We briefly talked about the 4 standard cardiac windows and gave some examples of the goal image we want to obtain in our minds when we're trying to image our patients. And then we briefly hit on some of the benefits and limitations of specific views of the heart, including why we might go for the parasternal long axis view over the short axis view and vice versa. We'll explore this more in more detail as we talk about specific clinical questions that come to mind when performing limited cardiac exams later on in this module. Can't wait to see you then.